Good afternoon, everyone. I'm Sandra Arevalo. I'm the Director of Community Health and Wellness at Montefiore Naya, bringing you once again community chats. Today, we're going to be talking about hair loss exposed, and who can talk about this better than our dear Dr. Kovets. She's our partner for everything cosmetology, dermatology, looking beautiful, like she is beautiful. And she works at Montefiore Einstein Advanced Care, just on the other side of the bridge here from Nyack. So we're very privileged to have her. And as I was saying to her a little earlier today, she still has the record on the most watched views of all of our videos because she's really phenomenal, and everything that we talk about with her is really important and everyone cares. So thank you so much, Dr. Kovets, for being here. We missed you.
Thank you. Thank you, Sandra. I feel like I'm privileged to be able to speak to the practice that I do every day. I speak to it with my patients every single day. And I hope this talk helps a lot of people today and going forward. And thank you for having me back because I've been busy. I have almost a 9-month-old, so he keeps me busy. But I am very excited and passionate about the work that I do. So I hope this transfers over. So I'm going to start sharing my screen.
And that is a very good reason for being absent for a little bit, right?
So, thank you. Thank you so much. So I'm going to just close this down like this. Alrighty. So community chat. Today we're talking about tips and pearls for management of hair loss in aesthetic setting. I did adjust this talk from the talk that I gave to the residents and physicians, and I gave this talk on some conferences, but I tried to open it up to a wider audience. And so we can try to address some things, and you have to realize that we are limited on time. And so I'll try to touch on some of the things that I think will help people. We'll talk about hair loss overview, how to spot types of hair loss there are out there. We'll touch upon the treatments. Please forgive me if I don't address the treatments because it's it's beyond the scope of this practice, and also it's individualized. And I will definitely try to answer many questions at the end. There are treatment options beyond medical treatments as well, which I do focus on as well, but I do try to address the main causes, and we'll talk about that throughout this talk. You also could realize that alopecia treatments are a billion-dollar industry. So since 2020, and probably a lot more since then, have been making billions of dollars, and it's demonstrating a booming market. But you have to be aware of scams and false advertisements and over-exaggerated claims. I can't tell you that I'll tell you all the answers, but there are some things to look for. And the one thing to remember, and I always bring this back to my patients, is that alopecia is multifactorial. It's not usually one thing, and we'll keep kind of going back to that. So when I talk about alopecia with my patients, I talk about saying that don't be scared. Alopecia does not mean it's like a terminal disease or anything like that, but sometimes it is an ongoing thing, but just means hair loss. When I say alopecia, it means hair loss. There's different types of alopecias, right? So loss of hair density is how thick the hair is, or sorry, density, how many follicles you have, and then either in one specific location or diffusely across the scalp. So we'll talk more about it. And again, hair loss is multifactorial. It's related to more than one cause. I set the expectations. Our goal is to identify all causes, some treatable. We will try to halt the progression, which can happen sometimes with inflammatory types of alopecia, which sometimes respond to treatment. And then sometimes, not always, we can reverse the hair loss. So we can try to reverse some of it if the cause is identified and it responds to treatments. So this is a slide, and there's going to be some busy slides. This is kind of an overview, but I will go into each one individually going forward. But to kind of set your framework, androgenetic alopecia, AGA, you'll hear me say AGA, it's male-female pattern hair loss. It's usually related to hormones, genetics, and unmasked by the next one, telogen effluvium, stress-related hair loss. We call it TE, telogen effluvium. Usually that one lasts over 3 to 12 months. And again, don't try to memorize all this. I will go back to this again, but it's usually related to stresses on the body, whether it's changes in the medication, surgery, pregnancy, physical stress, emotional stress, dieting, anything. Usually that does improve on its own 6 to 12 months when the stressor is no longer applied to the body. Then we kind of have this inflammatory shedding where even bad dandruff or psoriasis of the scalp can cause shedding and you lose hair. If we address those, that usually helps. And there's a group of scarring alopecia. There's primary, where it's internal, and we'll talk a little bit more about that. And there's secondary, when it's caused by trauma, by like pressure, chronic pulling on the scalp. It affects all ethnicities, but more common in skin of color patients like lichen planopilaris. We'll go into it again. You don't have to try to understand these terms. And Black patients usually are faced with CCCA, and this is another type of alopecia that is scarring. Chronic styling can happen, or internal inflammatory disease. And this is where you need to be seen possibly by a dermatologist if you feel like you have some of these symptoms. And often autoimmune disorders are predisposing people to have this type of primary scarring alopecia. And sometimes we need a biopsy to help with the diagnosis. So this one is so we'll start with androgenetic alopecia. 80% of women, 50% of men, probably more now because more and more people are kind of complaining of hair loss and coming out there. It's a lot more approachable now in the media. It is an interplay of genetics, androgen, which is hormone stimulation of the hair follicle, microinflammation in the scalp and in the body, and exogenous stressors. What happens is that you have in men and women, testosterone and DHEA gets converted to a damaging hormone called DHT. So you'll see a lot of the treatments out there are focused on quote unquote DHT blocking. And there's an enzyme that converts this DHT in the scalp and thought to lead to androgenetic alopecia. We think this is what happens, even though there's other things that are involved. So you see where the hair follicles becomes a lot thinner, and also there's less hair follicles coming out of each little hole. So that's what we call, if you hear the word miniaturization, it's thinning of the hair follicles. They're not thick like this. They are thin, like where this white arrow is pointing. Also, you have the decreasing number of hairs per follicle. So where you can have like 2, 3, 4 coming out here, you'll have 1 or 2. And this means it's probably related to the shortening of the growth phase and lengthening of the resting phase. And you don't have to get into all these details, but this androgenetic alopecia affects a lot of men and women. And it is actually thought to be associated with insulin resistance, with people with prediabetes, diabetes, and metabolic syndrome. So being overweight and other metabolic syndrome symptoms. So that was the first one. Now you also have telogen effluvium, which I had on that first, introductory slide. It's stress-related hair loss. It's non-scarring. It is usually shedding. Well, you'll see the shedding while pulling on your hair, brushing on the pillows, in the shower, in the sink. Just remember, it is normal to lose 50 to 100 hairs, even up to 300 sometimes, normal per day. If you have curly hair, sometimes it feels like you're losing more because it holds on, it's in your curls. And then when you brush it out, you feel like there's more than 50 to 100. Some people do count, and it's okay. I have people coming with clumps of hair. They're showing me they're finding in the sink that they're stressed out about. It's okay, it happens, but you have to realize you do lose hair daily, and don't freak out about it too much because stress begets more stress. This results in overall thinning everywhere. And you see more of the scalp when you're parting the scalp. And usually, and like I said, hair loss is multifactorial, but usually if it's just telogen effluvium, there's no itching, there's no scaling, there's no redness, it's just shedding. But it can unmask primary types of androgenetic alopecia, for example, or traction alopecia or scarring alopecia. So if somebody has thinning in certain areas because of hormones, it's going to unmask in those areas more. So continue with telogen effluvium, it can be related to major surgery, high fevers. We're seeing TE being a little longer with COVID infections, drugs. So stopping medications that can happen even in the last 3 to 6 months. Anorexia, bulimia nervosa, usually fat diets, especially in low protein diets. Childbirth, of course, we know like women can have great hair during pregnancy, and also they shed a lot. That usually is temporary. If childbirth happens later in life, it's not always reversed back to the really thick hair that we used to have, because we will have, besides this, also androgenetic alopecia that tends to get worse with age. Obviously, blood loss, it can cause anemia, nutritional deficiency. These are kind of making sense. It's stressing the body. Your body gets stressed and it sheds. You can also have serious illnesses that are either acute or chronic. So people can have chronic shedding just because they are, also have other serious illnesses like thyroid disease, renal, kidney, liver problems, inflammatory bowel disease, lupus, and proliferative disorders like, lymphoma and things like that. I'm not saying you have those if you have telogen effluvium, but those are some of the things that can make it worse. you definitely want to identify the cause. So if somebody had a recent COVID infection, in the way of kind of know that that's what's causing them to shed. And so we try to provide reassurance and time, and 3 to 6 months, maybe 12 months, sometimes at most, usually the shedding stops. You want to try to anti-stress, easier said than done. Obviously, the more you tell somebody don't stress, the more they stress, but it is a vicious cycle. So you definitely want to exercise, lead a healthier life, maybe meditate, something like that. All of that sounds cliche. Your hair's follicles are sensitive to things. So definitely try to anti-stress. Antioxidants, we'll talk a little bit more about that. I can't go into the details. I'm not sure if there's that much evidence on it, but we know that there's topical shampoos and solutions that are being used right now to de-stress the scalp and in the diet. And I think there is something to be said about this, just overall being healthier. You want to reduce chemicals. So if you are stressing your scalp out with using a lot of like shampoos that smell really good, so a lot of fragrances, I'm not saying smell is bad or fragrance is bad, but if you're more sensitive to it, or if you're eating a lot of processed diet foods, you might want to, be healthier because your body does, respond in shedding hair because of these things. And then sometimes we can use cosmetic things like platelet-rich plasma, which we'll talk a little bit more about that, but they can sometimes help stop the shedding. There's not really great data. If there was, everybody would come in to get PRP, but it's also $750 per session approximately, and you need like several sessions. So it's not always the first thing we jump to. And a lot of times, like I said, telogen effluvium is self-limiting. Now, this is a kind of a low-hanging fruit. The other type of shedding you can happen is from just inflammation in the scalp. So if you can treat your bad dandruff or even control your psoriasis, and I put these together because a lot of times they are like overlapping. So severe dandruff and scalp psoriasis can cause inflammation and make the hair shed. So the shedding is because in response of these inflammatory processes. Dandruff is a condition that's presenting because of the yeast overgrowth in the scalp. It can kind of be a little tricky because it can present in a few forms. It could be dry flakes that end up on your shoulders. Sometimes it's more oiliness, which is kind of confusing because it's dry, but also waxy plaques and oiliness, making the scalp oily and greasy, giving it less volume. I can cause inflammation. So people can say I have red, itchy scalp, but it's inflamed. And it becomes a vicious cycle because you're scratching, you're trying to pick at the scabs. And in severe cases, like I mentioned, they can cause hair loss. So we want to calm the seborrheic dermatitis or dandruff down. And we often use ketoconazole shampoo. It's 1% over the counter, or your dermatologist can prescribe, which is 2%. Psyllium sulfide, pyrithium zinc, all of these attack the yeast that can cause dandruff. And then you could use topical steroids, which are prescription, or injectable steroids sometimes for really bad dandruff. And that's done by your dermatologist, with your dermatologist, if that's appropriate. But it can look like, you can also, you may also know that you have dandruff in your scalp if you have some of these scales around your nose and your eyebrows or your beard. And it can cause a little bit more discoloration here, in skin of color patients a little bit more prominent because of the flaking of the skin, and it makes the tan skin flake off. You can see the skin is lighter here. It can also look very similar to psoriasis, and it's not your job to try to figure out what you have. And you, of course, go to the dermatologist to really help you with the diagnosis. But dandruff and psoriasis, especially milder forms, can look similar. Psoriasis is an autoimmune skin condition, and it's more of the cellularly white plaques. And some people can have it in other areas, and also kind of pitting and like changes in the nails. Again, that's beyond the scope of this talk, but if you have any of those, you may have psoriasis or a type of like a mild psoriasis in your scalp as well, if it's not really that bad. And then the treatment are, sometimes we can use actually, believe it or not, ketoconazole anti-yeast like dandruff stuff, but also we need topical steroids. Sometimes we do injections. And then if it's really bad or systemic, the dermatologist can use systemic immune suppressive drugs. Also, psoriasis, just of note, can be associated with joint pain that's worse in the morning, and can be associated with cardiovascular disease. So if you have a diagnosis potentially of psoriasis in general in the scalp or in the body, it's good to know that, especially if there's also cardiovascular family history, which would be good to keep an eye on that with your primary care provider. So besides the fact that you want to, stop your shedding of the hair if it's caused by psoriasis, but also be aware psoriasis is an inflammatory process in the body, which can affect the joints and the heart as well. And that's just like a little medical nugget, right? The golden nugget for you guys. All right, so we've talked about androgenetic, we talked about telogen effluvium, we talked about dandruff, we talked about psoriasis, now the scarring alopecias. Those can also be shedding and thinning, because alopecia can be shedding and thinning for many reasons. It can be an early sign of early scarring alopecia. The two most common ones are lichen planopilaris and frontal fibrosing alopecia, kind of grouped together. And then the other one is central centrifugal cicatricial alopecia. I learned to say that in a row, CCCA, especially in Black and other skin of color population. Sometimes these scarring alopecias look very similar. So again, it's not your job to try to figure out which one you have. But it is an autoimmune type of alopecia. And so it's more common in people who have autoimmune disorders like lupus or Crohn's disease or ulcerative colitis. They can have inflammation in the scalp. And they all can look very similar to you. Like, well, how can I tell a difference between psoriasis and, dandruff? And it's not your job. But if you are noticing, things like itching and scaling, and also there's hair shedding, and it's progressing, it's getting worse, you can try to do something about it before it gets to the point where it's scarring like this. So this is obviously below here as extensive cases, which were going on for a while. But the right diagnosis is important. Medical treatment should be started as early as possible to try to help, preserve a lot of the hair follicles, and possibly cosmetic adjuvant treatments. I never go to cosmetic treatments right away because you always want to, try to establish medical treatments. So secondary scarring alopecia is this traction alopecia. So the primary is when it's internal, like if somebody has autoimmune predisposition to autoimmune disorders and they get the LPP, CCCA. Secondary is from like external causes. So there's some kind of trauma, whether it was when you were little. People say, I haven't had, tight hair braids since I was like 5. Doesn't matter. Could have been that enough, several months to a few years of that type of hairstyle. But usually it's trauma to the scalp, usually chronic pulling. It's associated with hair grooming practices, usually in certain cultures, tight braids, tight ponytails, cornrows, dreadlocks that are heavy and pulling on. Even now, I'm seeing a lot of the hair extensions are pulling on the hair, and they're coming in with like early scarring alopecia because it's early and it's kind of reversible at that point. But if it's going on for several years, it is harder to reverse and to treat. Also, excessive chemical processing, like mechanical brushing and heat at the roots, can be also worsening these things, because the chemical and heat processing can make the hair more dry and more prone to more friable to trauma. And early hair loss is non-scarring from the traction, but over time becomes scarring. The treatments are obviously stopping the hair practice that is causing this. So it's okay if you've been doing it for years. You can always, if you have hair to save, well, maybe time to not pull on it so much. Topical steroids, we do prescribe if there's any inflammation or if it's recent. I do feel like there's some, let's say if somebody had an extension right here and it fell out in the last 3 months, I think it's worth trying topical steroids to calm things down, doing an injection there, and then maybe even topical minoxidil. We'll talk a little bit more about that. And then I always say there's going to be always underlying androgenetic, the AGA, the first alopecia we talked about, because everybody's getting old, perimenopausal, postmenopausal, men. We're all going to have hormones that can change and make our hair thin out. So we throw everything but the kitchen sink at it. So, but be aware, traction alopecia is out there, and it is usually affecting sort of the areas on the sides of the temples, which the other type of alopecia, I will also, like the first one, the primary one can affect it here, but it's different. It's not inflammatory. There's not a lot of red here. There's no scale. It's kind of burnt out a little bit. Let's move forward. So I always tell my patients, I do not want to miss scarring alopecia. I don't want to label somebody just as traction. Oh, you had tight braids. That's it, done. We can't do anything about it. That's when I do a biopsy potentially, because this patient had a biopsy proven primary scarring alopecia. I could have written her off and said, okay, you had tight, ponytails and hairstyles in the past. Can't do anything about it. But there is still ongoing inflammation, even though there's not a lot of redness here, but she may have been complaining itching or something like that. So sometimes biopsies could be helpful to try to see if there's still inflammation or if there's underlying process going on. Unfortunately, I see a lot of patients for evaluation after they had their hair transplant done, and then the surgeon just says, oh, go see your dermatologist now to manage your scarring alopecia. And I'm like, well, you should have controlled for that first, quiet it down, and then do the hair transplant if needed. And then we'll talk a little bit more about hair transplant towards the end. You do want to use medical treatments to quiet down scarring alopecia before starting any cosmetic like PRP, platelet-rich plasma, which I'll talk about, or considering hair transplant. Also, you can have AGA with scarring alopecia. So this person did have traction alopecia. She had, chronic pulling in her hair, but she has underlying androgenetic alopecia, which is related to hormones. And in her case, we could start things like topical minoxidil, which is Rogaine, or anti-androgenetic treatments, which are like block hormones, more relevant in women of non-childbearing age. This is all a little bit too much detail, but the point here is I don't rule anything out, and I don't say it's just traction from you pulling hair or it's just androgenetic. We always try to look for any kind of signs and symptoms. And so when you come in to see me or a dermatologist, we'll ask you about certain things. It's not 100%. We kind of are detectives and try to figure things out, but we'll ask about itching and pain. So sometimes you can have itching and pain and dandruff, psoriasis, and the scarring alopecias. Dry scalp scaling can be in some of these. If it's just shedding, a lot of times it is usually telogen effluvium. And then thinning overall usually is androgenetic. When I say thinning overall, like overall, but in specific areas. So we have different scales in which you use in men and women. And women, they tend to thin right here at the crown in the front. Men tend to have different patterns, but some of them have it in like the temporal areas and the top. You don't have to know any of these, but there's different patterns, and then we can mix and match. A lot of women can have the male pattern, and then some of the men have the female pattern. So it's not 100% by the book all the time. We ask about family history and, of course, recent stressors, surgeries, and things like that, to see if that's something that could have been happening to make the person stress out and unmask some of the other alopecias they have. And then we talk about the damaging style practices that they can be having. And when I look at the scalp, and again, this is like in clinic, I use my dermatoscope. I first ask about the temporal frontal, where I see where the hair thinning is. And I look at how easy the hair comes out. So I'll pull some of the hair gently, see how easy it comes out. I'll use my dermatoscope, which is it's a magnifying glass with a light. I'll see, is there a lot of miniaturization? Is there a lot of inflammation around each hair follicle? Is there redness? Is there scaling? Is there scarring between hair follicles? There's like not even any little holes left because they scar down. So this is what your dermatologist would be looking when they do an examination of your scalp. And so I look for miniaturization, erythema, just redness and scale, just pallor, which is kind of completely like, white. And then the follicular dropout is when you don't have a hair follicle left because it's been scarred down over time. Red, itchy, scaly scalp obviously should prompt consideration of scarring alopecia or autoimmune etiology. And then when we're not sure, we can do a scalp biopsy, but not always. Do not worry. You don't have to do a biopsy if you feel like you don't want to and that scares you and you think that every dermatologist is going to biopsy. Actually, a lot of dermatologists prefer not to biopsy because it's harder. So a lot of times you can have a clinical diagnosis and you can treat very similarly even without the biopsy. It's really important to check labs because, like I said, it's all multifactorial. It could be like shedding because of COVID, but also you could be anemic, right? Or your thyroid could be out of whack and you don't know. So you want to rule out internal diseases, nutrient and vitamin insufficiencies as looking at the whole body. So we want to optimize hair regrowth. So when I say it's like a garden, right? You want to grow beautiful flower and you want to make sure the soil is as optimized as possible because if it doesn't have enough nutrients, you may be trying to grow the hair, you're just not really optimizing it. So you want to make sure you're not anemic. So after lots of blood loss, it can happen, or there's other reasons for being anemic. It could be iron deficient, thyroid could be off, could be high, low. Sometimes people with, they have autoimmune thyroid issues. Vitamin deficiency. Vitamin D is an important hormone in your body. And then some people can be low in other B vitamins. We will check an ANA, that's a general screening for autoimmune etiology, rheumatoid factors if you have joint problems or joint issues. And then recently I'm going to start adding albumin because a lot of people are on these like weight loss drugs. And so you can have hair shedding potentially from albumin protein deficiency. So a lot of the surgeons that do these weight loss surgeries, or they do check the albumin. So I'm going to start doing that going forward. And so if hair loss is also accompanied by acne and hair growth on the face in the female, that could be potentially a hormonal disbalance with testosterone and a sign of PCOS, which is polycystic ovarian syndrome. And that's something that is, again, beyond the scope of this practice. But if somebody has that, you can try to evaluate those hormones with your gynecologist or an endocrinologist. But even if the hormones are normal, you could still have hormone-related hair loss, even if you have other symptoms. So it's even if the labs are normal, it doesn't mean that there could not be something going on hormonally. So that was an overview of kind of like how we evaluate type of hair loss you have and potential. Hopefully we can try to identify some things, but there are usually our treatments are focused on androgenetic alopecia. So the FDA treatment approved for AGA, androgenic alopecia, are oral finasteride, which is a hormonal blocker. Remember how I said that that damaging hormone DHT was what we think, causes some of the thinning in the temples and the vertex of the scalp. Topical minoxidil, this is the Rogaine that you hear about, either 2% or 5%. I don't ever use the 2%. I go with 5% or more for both women and men. And low-level light therapy. So it's not a true laser necessarily because you could use it at home. I mean, it's still unsafe for your eyes and if you're shining into your eyes. But the low-level light, there's the red LED diode things that they use at home, and I think we'll touch upon about on that for a few minutes. We have done some meta-analysis out there, and they know that for men, topical minoxidil has been working, oral finasteride and low-level light therapy, and the best evidence showed, and women, topical minoxidil. But I think it's been so long since we studied this. There's definitely evidence for all of these working for women as well. So again, this is part of the talk that I gave to the physicians and the residents. We talk about the different evidence, characterizing evidence, how it works for males and females. They definitely show that actually PRP, low-level light therapy, this is another hormonal blocker, dutasteride and finasteride, minoxidil topically, and even Latisse, vimetopros, has been shown to help with male androgenic alopecia. And in females, they've shown that some light therapy and minoxidil has been studied. But this has been a couple of years back, so we definitely need more studies on this. Now, this is a busy slide. The reason I kept it in my talk is that a lot of people talk about, should I be started on Propecia or oral finasteride? So a lot of men ask about this, and it's a chronic medication. You start taking it, you block the DHT, the damaging hormone here, and you just continue taking it to help the hair not fall out. Dutasteride is another oral medication version of this, just for simplification. Men and women can tolerate both these medications. Partial regrowth, so not everybody responds. Not every medication is perfect like it is in other medicine. So 66% of the patients do respond. There is a systemic reduction of this hormone. So we don't know what other implications of the balancing of other hormones happen in the body. So I do not prescribe this oral hormonal blocker with a history of breast cancer because I don't know how the estrogen gets affected in the body. And then recently, there's a post-finasteride syndrome that's been identified. Doesn't affect a lot of men, but it sometimes can cause erectile dysfunction, probably related to dose and duration, and then could be in more predisposed individuals, and there's some psychological depression associated with it. For the most part, most people do stay safely on this medication. It is being evaluated for this now, so I'm always keeping my ear to the ground. So it is something that we can give chronically. But a lot of people don't want to deal with the systemic medication, even a risk of anything. So it pushes doctors and patients to explore other options. So let's move on to topical minoxidil, mechanisms of action. So it's a really underused topical, I call it epidermal growth factor. It's not a growth factor, but I think it does a lot of things on the level of the hair follicle, which if you can tolerate it, and we'll talk about how people can't tolerate some of the side effects actually, but if you can tolerate it, increases blood supply to the scalp, increases DNA synthesis in the scalp, increases the growth phase, which is the anagen phase, and increases the survival of the dermal papilla cells, where the stem cells are around that area. So I counsel my patients and I tell them there's two versions usually of topical minoxidil, and it has the best evidence for it in general. So it's the longest study data for alopecia patients. You can get temporary shedding when you start. in the first couple of weeks. Not everybody has that, so it's a little scary for somebody who's already losing hair. So I think it's more traumatizing women with longer hair because it takes longer for them to regrow that longer hair. You can also get shedding after stopping. So most people are like, well, I don't want to be locked into using this forever, but you would have lost that hair anyway if you're not using it. So people think, oh, I'm going to lose more of it. No, you're just going to lose the same amount that you would have lost anyway up to that point from when you were 33, for example, to 35. But it just may feel, when you stop it, it starts to shed, and you may feel like it's a lot more than it would have been. You can also have an allergy or irritant contact dermatitis. Usually it's the propylene glycol. So if you know you have an allergy to this, you definitely need to use the foam instead of the solution. So I'll mention that later. So yes, right here. And you can have decreased irritation and better permeability. However, the alcohol in the foam can add to some more irritation because it's more drying. So you have to kind of pick the two. Which one do you think? If you have no sensitivity to propylene glycol, you can try with this. Some people who are very sensitive, then you can go to alcohol unless your scalp is very, very dry. And so there is some, you can add it maybe, there's some compounded version of this that we can get, but it's out of pocket. Again, too much detail. Right now, we're talking about just topical minoxidil, 5%. You can also have hypertrichosis, which is excess hair on the forehead and other areas of the face, which even if you put it on your scalp, people start to grow hair on their face. And then rarely headaches. So basically, this is the discussion. Usually, you can have a little shedding in the beginning. You can have some irritation. If that happens, we can try to give you some topical steroids, and then you can have some hair grow on your face. That's more relevant in women. Compounding pharmacies are being used. It is out of pocket. If you can't tolerate propylene glycol and alcohol-free, sometimes you can do it in ointment form. Again, you have to find the right pharmacy, and it's usually $55 or up. Non-responders sometimes benefit from higher concentration. So let's say they're using 5% topical minoxidil, but we want to go higher, and they're doing it twice a day. We can go higher. You can also add things. So if you want to not take oral finasteride, you can add topical finasteride. You can into the minoxidil. You can add other things like caffeine, melatonin, cetirizine, and Zyrtec. Now topical steroid, tacrolimus. They even put tretinoin. So there's all these little small studies that came out, and so the pharmacies are like, well, they're showing evidence. Let's just mix it all together. Again, it starts at $55, $75, $95, over $100 per bottle per month, potentially, depending how often you're using it. So it depends on the pharmacy, and that's a discussion between you and your provider. You can alternate it with the 5% over-the-counter minoxidil. That's something you could do. So you can get finasteride minoxidil and see if that'll help. Again, it's all trial and error, and see how you tolerate first minoxidil. So don't jump to this until you know how you tolerate 5% minoxidil. I use an FDA-regulated 503B compounding pharmacy called SkinV, SKNV. Your physician provider will know about this. And so I compound minoxidil finasteride. This does tend to be irritating, so I have to prescribe a topical steroid with this. It's an option. So I know it may be feeling like too much information. Again, you can just start with the over-the-counter minoxidil, and that should be okay. Let me just say one more thing. Costco, Kirkland brand would be like 6 months supply for $60. You shouldn't pay more than about $10 a bottle, so $10 a month, because all the other ones out there are all the same. So also don't pay the pink tax. If they're saying it's for women's, and it's usually less amount and they charge you more. So 5%, even men's strength is fine. They're all the same ingredients. Just check on the back. So low-dose oral minoxidil, you probably heard about this miracle drug and recently popular. This slide was more made for my residence physicians, too much detail, but basically we used to take this medication for blood pressure. It was a high side effect profile. So they went down to like a quarter of 2.5 milligram tab for women, and a half to start at 2.5 milligram for men. And we realized that because it vasodilates, it increases blood supply to everyone in the body. It helps all alopecias, but it's more studied in androgenetic alopecia. Usually, just like with topical minoxidil, you can actually have hirsutism, which is a word for excess hair in body parts, especially for women. This is noticeable. You can have a little blood pressure that's low, lower extremity swelling of the legs, and pericardial effusion. So obviously you wouldn't give it to the patient who has any predisposition to CHF. But it is tolerated well. Hypertrichosis is excess hair on the face is dose related. So a lot of dermatologists prescribe this because it has a lot of advantages. It's convenient. There's no residual color change because you take it by mouth. Cost is less expensive than topical minoxidil. Co-therapy, you could use it with other approaches. And compliance, because it's easier sometimes to take a pill than to put something topically on. And this is just a slide. It's a busy slide, but it just shows you. So it over time, and the higher the dose, the hair diameter and density does increase. This is what we said that usually is lowered in androgenetic alopecia. And it's dose dependent. So the hair growth and cardiovascular effects usually are the higher the dose, the higher the chance of the effect. But it's not been associated with very high blood pressure changes, and the safety profile has been favorable. So a lot of people do take it, but it is a medication you have to take every day. I mean, this is something, if it's working for you, and hair loss is very, very, very personal, and it's emotional. And if it's something that can be tolerated by a patient, and you can have that discussion with your provider, it is an option for many people. I also like to do a separate slide for ketoconazole shampoo, because I think especially for people who have dandruff and oily scalp, I think it can help decrease some inflammation and give them a little bit of volume. But also it kind of blocks some hormones. It's anti-inflammatory and blocks the androgen receptors, which we talked about having effect in androgenetic alopecia. I always tell patients who have oily scalp, you can't lose by using it. And then always use it in the scalp roots. So if you're using over the counter, 1%, this is the 2% that's prescription. Just don't put it to the rest of the hair, because they make the rest of the hair brittle, so use another shampoo. But there is something to be said about blocking some hormones in the scalp. Now we're going into an area of where you're probably starting to see, and I'm sorry, I can't give you, I can't tell you like, take this supplement because that's going to make your hair grow. Because one is, that would not be, I wouldn't know 100% if that's the case, but there are certain ingredients that you can look for, and you can make an educated guess about what, or educated choice about what topical supplements you can take, or oral supplements. So when patients ask about over-the-counter ingredients, there may be some science, but it's still early. But a lot of them focus on DHT blocking. Like, remember how I said this damaging hormone in the scalp? Because where finasteride orally and topically blocks this, there's also some sort of like more natural quote unquote things like saw palmetto, green tea, pumpkin seed oil, and then I think other oils that are supposed to help with androgenetic alopecia. And there was a recent review that had some evidence for saw palmetto, caffeine, melatonin, marine extracts, rosemary oil, and other things like that in male androgenec alopecia, and I'm sure in females as well. We'll come back to this one a little bit. There are a couple of over-the-counter oral supplements that I did some research on, and maybe that could be useful for you. Now, regenerative medicine, just to touch upon it, you probably have heard people getting either platelet-rich plasma injections, stem cells, or extracellular vesicles, or probably more recently known as exosomes. I'll just kind of give you my opinion about this. So PRP is that the original use of PRP was the vampire facial, when people like took it out and did it on with microneedling in the face. But we know that there is strong evidence for, and meta-analysis means like when they pulled lots of different data from different studies that show it helps with androgenetic alopecia. It's basically autologous, which means we get it from the patient. We take your blood, we take out the red blood cells, we spin it out, and then the plasma is there at the bottom with the platelets. And then there's a lot of growth factors in platelets. When you cut yourself, those platelets go in there and they release things to help you heal. And that's what we focus on. They're like basically rich in all these growth factors. Busy slide, do not worry here. We're just here to tell you that platelets have androgen blocking, sort of like they work on the pathways that potentially can block these bad androgens and hormones that can cause hair loss. They can also promote hair growth by activating certain pathways to make the hair grow and increase blood supply through VEGF. Angiogenesis means increasing blood supply. So the hair follicle is right here, all these growth factors acting on it. And so we want to protect this hair follicle by increasing blood supply. So minoxidil works around here by increasing blood supply. And that's why all this area is so sensitive. The stem cells are so sensitive at the base of the follicle. That's why we don't want heat. We don't want pulling there, because that's where the action happens to make the hair grow. There's a lot of kits out there. And again, this is more speaking for people who choose which kits they're out there, but there's a lot out there. But most of them spin the blood out and get the PRP, the platelet-rich plasma. And this slide just means that we think that higher concentration is better for hair loss. This is a summary. We found that PRP was the topmost ranked treatment for androgenetic alopecia, even though we have FDA-approved treatments, minoxidil and finasteride. Low-level light therapies, those red lights for androgenetic alopecia, has been helpful and been shown to work. And in this one study, it showed that actually it was as good as finasteride and minoxidil. There is evidence that PRP works, but again, every person's different and you're getting it from the person. So every person's PRP could be different. If they're not healthy or if there's factors that make their platelets not work well, we don't know what we're getting because it's from the person. You're re-injecting it. So it's not yet approved for alopecia. It's possibly as effective as other treatments that are FDA approved. Again, it's not a magical drug, and it changes from person to person. So this person, she was postpartum a few months, so she was having hair loss. So she probably had androgenetic alopecia and telogen effluvium, which is that stress-related hair loss. And then after 2 sessions, she did regrow a lot of hair. Could you have said that maybe she would have regrown it anyway? Could have been the case, but it helped her get there faster. This person was more, we were struggling more. There was some improvement. However, this person also had metabolic syndrome, possible autoimmune things going on, and other comorbidities. So there's uncontrolled dandruff on and off. So you could see there's like some scaling here. So she did have a little bit of a response from the PRP, but it was not as good as because of other factors going on in her body and also on top of the seborrheic dermatitis. There's 2 perspectives on what PRP can do. We can sometimes also use microneedling with PRP, where we take PRP, this is the plasma, we take the microneedling we could use on the face as well. You see this person had microneedling on their forehead. And then we can do the actual microneedling of the scalp actually helps regrow hair. That's one thing. And then if you're adding PRP on top, so we either inject it or we put it through microneedling. So we know that the growth factors stimulate the stem cells and then increase blood supply and increase collagen. But I think the two together should be combined if it's possible. And it's not always, these results are amazing right here. It's not always like that. And I think every person's a little different, like I said, so take it with a grain of salt. So we either inject or we do microneedling or we do both. So injections hurt more. Microneedling, we try to put topical cream on. Some people don't use topical cream. And then we infuse the PRP through this way as well. But injection does go deeper in the scalp. Best results seen in combination treatments. So you want to put topical and oral together. So if you could do oral finasteride, somebody's taking finasteride per P shot, and they're doing topical minoxidil, great. And the best improvement you'll see at 3 to 6 months or longer, because it takes 3 months to see any improvements with hair loss from any treatments. And we do know if you keep using minoxidil, and if you can continue to use it, it can help you longer and more. You can mix finasteride, potassium minoxidil. Sometimes people, they do PRP injection and microneedling, low-level light therapy and minoxidil. You can do hair transplant with oral finasteride and low-dose oral minoxidil. So there's a lot of mix and matching. And so what is right for you would be probably determined by your side effect profile, how well you're tolerating that medication, whether it's topical or systemic, and what is what's available to you, because low-level light therapy is out of pocket, and so is PRP and microneedling. There are options. They're not perfect, but it is something to consider. Really touching quickly upon this, there is such a thing as doing a little like fat transfer to the scalp, nanofat. So there are stem cells that live around fat, and we don't do this in our office. I did it a few times before. The stromal vascular fraction has stem cells basically, and so you micronize it and inject into the scalp, but it's a lot more involved, and it's almost like a little mini liposuction. So just be aware it's out there, and maybe it'll get more traction. I think more surgeons do this, plastic surgeons, because they're available. They have that equipment available, and some of these, if you find one and they offer like good results, consistent results, then it's worth possibly doing it. But I don't know too much about this because I haven't done this recently. We talked about PRP, platelet-rich plasma. We talked about a little bit about fat potentially. So exosomes have been recently coming into the market for hair loss. And about a year or so ago, everybody was like injecting them and using them topically and everything because they do have promise and they are pretty amazing. They've been the newest craze in regenerative medicine topically as well for post-procedure and also like rejuvenation wise. They're extracellular vesicles, EVs, exosomes, and they act as cell-to-cell transporters. So basically they're messengers, but there's like so many of them and we don't know exactly what they do yet because the science is so new. Platelets do carry actually exosomes on them. So there's some, interplay there when you're getting PRP. And we think that they work through certain pathways that's similar to platelets where they stimulate the stem cells to stimulate growth. And it showed really nice improvement in case reports. However, there was lack of clinical trials. And then also there were some adverse events, like I think there was some sepsis and infection using exosomes. So FDA issued a warning about exosomal therapy, especially injected. So we're using it topically now, but we're not injecting it. And some people are, I guess, injecting it, and they're probably seeing improvement, but it is strongly, I don't recommend for providers who are doing this because you can get in trouble with the FDA. But topically, we are using it. The one caveat is that, so the good thing is with exosomes is it comes in a little vial, right? So you don't have to stick somebody's arm to get, PRP, you have to stick somebody's blood and spin it out, but then there's variability when the body's platelets and growth factors that you produce yourself. So this is your own product, but it varies depending how old you are, how healthy you are, on all those things. With exosomes, it's a little bit more consistent, I guess, because it comes from an outside source, but look at where it comes from. It can either come from platelets, umbilical cord, adipose, bone marrow, perinatal, mesenchymal stem cells, and then plants. I don't know, plants, I don't think there's much cross-reactivity with plants and humans, so I don't know if those work. But there's still, so the above ones here are from another person. So we do, obviously, we get blood transfusions and things like that, but it is something to consider. You are getting it, that's after it's been tested, quote unquote. It's coming from another source, not you. And it's not synthetic, it's coming from another human being. They're recognized as drug products. They are, stringently, I guess, there's stringent rules about it, like I mentioned. Is there a risk of transferring genetic material or immune response? I don't think we know that. We know they're tested very rigorously, and then, and it's very clean, I guess, quote unquote, whatever that means. It's not FDA approved right now, but people are using it topically. So I just to say that I don't know, I'm torn myself. I would love to use exosomes, but can we get it more clean? Can we guarantee that we're cleaning everything out when we're getting it? So basically the platelet-derived exosomes that are common right now, they're called plated. They're using topically, and they have a serum for the scalp. They basically take it from blood banks that are, not expired yet, but they're about to expire. Blood banks that do blood transfusions. So they take these, and then they make exosomes from these platelets. So I think they're regulated by the government. I guess the blood banks, they are, so it makes you feel like, okay, it's clean. But again, it comes from a pool of donations. So I'm just going to leave it at that. And I'm not sure where we start. And I think it's a great concept. And I actually personally have used, topically to post lasers and things like that. And it does help. But there's that question. So leave it all to you to think about. Nutraceuticals, notable ingredients. So we know that there's evidence for androgenetic alopecia for many of them. They've claimed to work on intrinsic and extrinsic causes hair loss, so like maybe stress-related things, antioxidants, minerals, vitamins. Some of them claim to block DHT, like I mentioned. All of these ingredients and probably much more. So it's a busy slide. I apologize. I just needed to include some of the things that, like ashwagandha is supposed to, regulate your cortisol levels to help you be less stressed. The marine collagen increases the structural integrity of the hair follicle, for example. Turmeric, it's supposed to be anti-inflammatory. Some evidence it inhibits the 5-alpha reductase, which, converts the DHT to DH, makes a damaging hormones. Red clover is supposed to inhibit the enzyme that converts it to the damaging hormone. Amino acids, precursors to collagen, that can help your hair grow. What else is here that we hear about? Iron, zinc is in them. Sapelmeto is big in inhibiting 5A reductase and a lot of the oral and topical supplements. There are some safety concerns, and again, busy slides, I understand, but like try to take some things away from some of these. Let me just take a little sip. So most of these supplements are not verified by independent testing agencies. And so just take that with how you just to be cautious when you take things and put in your body, as with any consumables out there. When you're consuming a supplement, you always have to make sure that the company you use, it's been, at least verified and has, I think there's sort of like NSF and other testing facilities that are testing some of these. And then the very high doses of vitamins and minerals are just not good. So for example, high levels of biotin, and I know we all hear about Nutrafol, and I have nothing against it. I actually take Nutrafol on and off, but if you take high levels of biotin, it can actually affect your thyroid testing. And here it says troponin and other tests. Saw palmetto can affect your warfarin levels because increased bleeding. Hydrolyzed fish collagen. What if somebody has anaphylaxis to the fish? You have to be looking at these things. I know these like risk of cancer and things like that. I don't know if that's really that true. I don't know. But for example, let's see. There's obviously dyes and preservatives to be aware of. High dose selenium, and they said it's a high melanoma risk. I don't know. I can't speak to that. So there's just like evidence that are like put out there, and you just have to be an educated consumer when you consume things, especially if it's relevant to you. So if somebody takes warfarin, some of these supplements can increase your bleeding capacity. So you have to be careful. So tablet sizes can be big. Melatonin obviously can make you sleepy. High dose vitamin C can cause some kidney stones. High dose iron can cause constipation. So things like that, I think, just to consider. But there are this was a CME talk, so I didn't have the brand names, but this one is Nutrafol. This one is number 2 is Viviscal. Oh, I have to see what number 3 and number 4 is. So they're like all these different ingredients that the different companies put together. And they sometimes you might think that one is good for you. Like if you don't want to take the marine complex because it's from shark and mollusks, you might be allergic to it. I want to skip this one altogether. The Synergen complex from Nutrafol, you might maybe not be able to take because it has cod allergy and blood thinner, but other ones maybe not having any allergy cross-reactivity with you, and you might choose those. And there's some people prefer biotin-free ones. It still has saw palmetto and ashwagandha. Saw palmetto to block the DHT, and ashwagandha is supposed to be helpful with the cortisol levels. And polypodium leucotomus is an antioxidant. So there's probiotics that we think are good. So I'm not pro and not recommending these for you to go out and buy them, but just unfortunately, because if there was FDA trials and then approvals, then I would be able to like speak to it more freely, like say, yeah, let's do this. But these are all personal choices based on what your allergies are and what you need. So I know that we have about 3 minutes. Sorry, Sandra. I wanted to speak to lights and laser therapy in hair restoration. I think there is something to be said for light laser therapy at home. There are many FDA cleared devices, and this is the top part is like the photobiomodulation red light and infrared. And I think there's something to be said to be using those 3 times a week for however 10 to 30 minutes, depending on the device. And below here are other lasers that are more like ablative and non-ablative, which are done in the office. So quickly, the caps, the wands, and all these things, they do work. You have to choose the right one. Sometimes some work better than others. And the ones that are more expensive are the ones that probably have more of the light emitting diodes. So if one has like 60, like I'm speaking about the ones for the face masks, similar idea how you choose them, versus the ones that have like 100 or 200. So I think they work better when they have more diodes. And you have to look for the ones that like are not super cheap, because then you can't you're going to heat up the scalp more than do anything else. So it has to be a true LED device with infrared. And there's different evidence for different ones. again, so like the Hair Max was the original one. The Hair Max comb, and that one starts at 300 plus. There are other ones, I think like Costco, sells Iris Store. And I think there's other ones that are, I can't think of the names because I'm not really, we don't sell those in our office. But make sure it's FDA approved and make sure it has specific light that's emitted and it's vetted. So there's a high compliance rate because there's no side effects and you could use it 3 times a week. Costs anywhere from 300 to like thousands of dollars because the number of diodes are in there. You have the wavelengths, number of volts, power, and energy. Beware of cheap models. And overall, it does work, but you have to use it for like about 180 times or about a year, So it is something you can add. This slide takeaway is low-level light therapy plus topical minoxidil works the best. So combined therapy from here in the bottom, here to here, she had the best improvement compared to using light therapy versus minoxidil alone. So combination treatments do work. I'm not going to go too much into these different lasers you could do in the office. I don't think that they're perfect. I think they work for a specific type of alopecia, maybe specifically for androgenetic alopecia. There's different lasers out there, and one of them is called LaceMD. Specifically, that one has been around for hair. Different ones. These slides were made for, I guess, people who like use lasers and things like that. So I'm going to go through these really quickly. They're just to show you that there are some lasers. There's some offices that are offering these, not covered by insurance, to help with hair loss. And then some of them, they do combine them with other things like minoxidil, nutraceuticals. So like I said, it's not always just a laser. If you're in the real world, if you're not doing a study, you are going to you can probably be offered many different things. You may be offered PRP injections with laser, and maybe you need to buy a low-level light therapy using with topical minoxidil too. Really briefly for hair transplantation, I'm not a hair transplantation expert. I'm here to give you just an overview. What are some options for hair loss? And if you have stable hair loss, meaning it's not scarring, it's not inflammatory, and you want more density and you have hair in the back, you can transfer the hairs from the back to the front if you have a good donor area. If the medical treatment has been unsuccessful, you could do it for people who are, want more density. So basically, you would not do it for somebody who's really inflamed or who doesn't have a lot of hair overall. Because what they do is they take these little punch. Right now, it's called follicular unit extraction. And they take little punches from the back of the scalp. And these hairs in the back of the scalp get transferred over to the front or the temporal area or from the crown, wherever they need it. And the satisfaction rates of these are 90 to 97%. The graft survival rates are pretty high for male androgenic alopecia. It's not suitable for ongoing scarring alopecia or alopecia areata. And also there's special considerations for Afrocentric hair. I think you have to go to the expert that does this all the time. But basically, you want to extract they extract the whole hair follicle, the whole thing, they punch them out, and they transfer it over to the front. And it's actually suitable for all of these, male androgenic, female pattern hair loss. Sometimes they do it for eyebrows, but I think that one is to really be done by an expert because it could be a weird direction in which it grows. It can be done for hair, for people who have scarred from trauma, they can transfer it over there. People who have really high foreheads, and then they've actually transferred it over to make the forehead smaller. Not suitable, like I said, for primary scarring alopecias like LPP, FFA, and lupus, or anything inflammatory, just going to fall out. You're going to waste your money. This slide is busy. This is just to describe hair transplantation can be used robotically. You could use the punch graft. Some people even cut the whole strip of hair in the back, and then that requires a scar. That's usually that's what they usually used to do. Now they have more of the follicular unit extractions. Complications are rare. Usually it's just like a lot of swelling because they have to do all this numbing in the scalp, and there's some bleeding. It could be a little folliculitis, like hair follicles and numbing the scalp for a while. You can have shock hair loss after the procedure. And then it just kind of goes away in 3 to 4 months. You can have little ingrown things from like where they put the hairs. They can have a little ingrown hair there 2 to 3 months after surgery. You can have rashes and things like that. And also if somebody has is prone to keloids, I think that's a discussion to be had with the patient. But you can have little scars still in the area where the follicles are extracted as tiny little scars. So if you have a lot of hair in the back, you might not see it. If not a lot of hair, it might not be an option. So this is a summary of evidence for alopecia treatments. Strong evidence for topical minoxidil and oral finasteride. Oral minoxidil, it says moderate evidence. I think now, this was an older review, 2021. So I think there's stronger evidence for oral minoxidil if you're able to tolerate, because it does grow hair. Platelet-rich plasma has strong evidence. Exosomes has moderate evidence. Microneedling, weak to moderate. Oral nutraceuticals have moderate evidence for alopecia treatments. Marine complex supplements, moderate, and there's light devices and hair transplant have strong evidence for improving hair, but you have to be the right candidate for the hair transplant. Light devices, I think, also work, but you have to use them for androgenic alopecia. So in conclusion, I always want to make sure if you have early signs of scarring alopecia, like red, scaling, itching, burning in the scalp, and somewhere you can't see, go and see a dermatologist because you don't want to miss scarring alopecia, and see if you can do something early on to preserve those hair follicle count. You want to treat dandruff and screen for vitamin deficiencies, because just in case you have, your iron deficient, your thyroid is off, and if you could just fix that or try to control that, it can make a difference. And a lot of it is synergistic approaches, right? So we can use topical minoxidil with oral finasteride. We could use PRP. Exosomes, I guess, are out there now. Microneedling, low-level light therapy, and some lasers in some offices. And the best data is for topical oral minoxidil with finasteride, PRP, and low-level light therapy. My current approach is I do recommend minoxidil topically if somebody is willing to do that, and more chronically. Low-dose oral minoxidil is on the table, but we always try. I try to do less is more in the beginning. And office PRP is offered in our office. I think it's more of a supplement or kind of additional treatment rather than a primary treatment. Home low-level light therapy, I think it's reasonable to try for people who have androgenic alopecia. Nutraceuticals are out there. Just beware of really, really high biotin levels, or maybe like take it for 3 months and then stop. I think taking care of your body is just important, eating healthy. And I think that's something to be, said for all kinds of skin problems. And you may want to do a supplement with compounded stuff. So compound topical finasteride, minoxidil, if you don't want to take oral finasteride, that's an option. And then the hair transplant, more money, but it is an option. And I think you should talk to several surgeons. You could just Google in your area, go for a consultation, ask them how many treatment patients they've treated and what their, what their chances of improving in your case. And I think just ask a few before you decide to go with somebody, because it is an out-of-pocket investment. So thank you so much for your attention. I'm going to just maybe I'll continue to share for a while if I have to get back to the slides if anybody has any questions. Can you hear me, Sandra? Okay. So I think that, okay, Sandra had to go to another meeting. So so there's any recommendations for patients with Lyme disease, Bartonella clinical, all this bearing, okay, diagnosis with Babesia. So I think chronic inflammation is really tough to address because you can see we can barely try to fully cure or treat things that we know about, you know, they're more better characterized, like androgenetic alopecia. I think that would be, I would not know what to do with those people, because if they have chronic inflammation and chronic microinflammation in the body, I think the best thing for me to just go to better lifestyle, like diet that can increase more healthy foods, decrease processed foods, antioxidants. Maybe it'll help the body not be so inflamed. So I think the gut is like the skin inside out. So I think there's a lot to be said for treating body inflammation, especially something we don't know about with like maybe probiotics and things like that. But that is not my area expertise. So what is your opinion using stem cells for hair loss? What you can tell us about it? So hair loss definitely used to respond to stem cells a lot, and stem cells are used very often, in my experience, by surgeons, plastic surgeons, because I think they have equipment that allows them to like you kind of invest in that. I think you're not allowed to advertise stem cells anymore in certain states because of the FDA regulation. I think it definitely works. There's like PRP, there are different stem cell extraction kits out there, and some are very, very involved and very expensive. So I think that there is a way to extract stem cells, but I think they have to come from your fat. If you're to get, you know, stem cells from your own fat. I think that it's all new to all of this. We're all new to all this regenerative medicine technology, and it's improving every day. I don't use stem cells in my practice right now. And I think a lot of people are not allowed to say they use stem cells anymore. Some people got into trouble to take it off their website. I have autoimmune issues, psoriasis, Crohn's. My dermatologist told me to use tar shampoo. Do you think that helps? So I guess it would depend on what your scalp looks like. I think tar shampoo, like T-Sal is Neutrogena salicylic acid, and there's T-Gel. T-Gel is a tar shampoo. It's stinky a little bit, but I think it's anti-inflammatory. So I think it is one of the options to use, but it depends on what your scalp looks like. So if somebody has autoimmune issues and they don't want to use topical steroids or topical injections, I guess you could, like, you know, look towards other treatments that can either decrease your yeast overgrowth on the scalp if you have a lot of yeast and dandruff. They can sometimes even help psoriasis, and try to decrease any parabens, like excessive perfumes that can flare the scalp. And I guess I would have to take a look at the scalp itself to see what other recommendations I would do. I think tar shampoo, there's something to be said for tar shampoo, but there's other things you could do to descale. I like clarifying shampoos that you alternate with regular shampoos. Your scalp needs to be descaled. You know, like sometimes it's all this products get built up on the scalp. So I have to, I will recommend patients to use like a salicylic acid or something with tea tree oil in it, with rosemary, but not all the time. You want to alternate it with the regular shampoo. So I like Neutrogena T-Sal shampoo. It's rarely available. If you're not sensitive to fragrances, I've been recently, like Hask, I used their scrub. Nutrafol actually has a scalp scrub as well. That one does not have fragrance in it, and it helps establish the microbiome of the scalp. So I think you don't want to be scrubbing your scalp all the time, but you definitely, there's something to be said about gently scrubbing it if you have scalp buildup. But if you have painful, inflamed scalp plaques in your scalp, it needs to be calmed down first before you just scrub. So definitely medical management is first in my book to calm inflammation. And I'm not afraid of topical steroids because they help more than hurt if you use them the right way. Let's see, would PRP help someone who has inflammation? So good question. So inflammation internally, if there's scalp inflammation, I usually start with topical steroids and injection of steroids for a few sessions of those to see how it looks. If there's scale and redness in the scalp, because I think PRP is anti-inflammatory, but it just feels wrong to skip the medical treatment first. But if it's Lyme and chronic disease, again, it's a tough subject because it affects the body in such a strange way and differently in different people. And of course, hair loss is one of those symptoms. I think you could try it. I don't know if PRP will help in Lyme because I would have to do some more research. But if it's available to you, I think you could try it. It is anti-inflammatory, theoretically. So if somebody has a lot of psoriasis in the scalp, there's also, besides topical steroids and injections, I don't like to do injections all the time. If it's something really, really bad, you can also just get on a systemic treatment. And I don't do systemic psoriasis treatments anymore. I usually refer to a medical dermatologist who would manage the psoriasis in other ways. And if you have other symptoms like joint pain and God forbid, other plaques and other symptoms on the skin, I think it's worth talking to a rheumatologist who can put you on a biologic, and that can help both your joints and your scalp and your skin symptoms. So there's a lot of biologics out there. And again, I don't do biologics in my practice because I am subspecialized. Otherwise, I would have to clone myself to do more of the medical stuff. But I do refer to a medical dermatologist who can help either manage the psoriasis or refer to a rheumatologist that can manage the other systemic symptoms. I think I answered all of the questions. I hope that was helpful. Sorry, I don't hear. I only see the notes here. Let's see. I answered all of them. So not seeing any other new questions at this point. Oops. All right, guys, good luck with everything. And if it's mild symptoms, you can try to do some things over the counter. But obviously, if your symptoms are progressing, if you have excessive shedding, excessive itching, pain, clumps of hair coming out, obviously could be alopecia areata. I didn't mention that because that's something that's clear. A lot of times, just like looks like the hair has been shaved off like this. Definitely go see your dermatologist, and it can help you get started on trying to treat the treatable alopecia at least. Okay, bye. Oh, I didn't see you. I don't hear you, Sandra.
Oh, sorry about that. Thank you so much. I have to take care of some things at 1 o'clock, but that was fast. So thank God I'm back. And
Okay.
were you able to answer all the questions in the Q&A?
Yes, all the questions that came up.
Perfect. Thank you so much.
Okay.
And people are saying thank you so much for all this information. So as always, you've been wonderful. That was a lot of information.
It was.
To shrink in 1 hour. So that was perfect. So, and thank you to all of our attendees also. We hope that you find this information useful. And please join us next week again in another community chats. And no worries, we're gonna have Dr. Kovets back. I know you love them. So thank you so much. And I will see you soon.
Okay, have a good week.